Oh, Jan, thank you. Thank you for reading that, and thanks to my mother for writing it. Yeah. So I'm delighted to be here. I love talking to at the symposium that Jan arranges, because he always gets a group of really committed practitioners. And if there's anything we need in the obesity epidemic, is knowledgeable providers. So I think one of the issues with being effective in weight management as a pathway to better health for our patients is I think we're not all on the same page in how we think about obesity. I think we're sort of mired in an old way of thinking, and that old way of thinking tends to produce the same old results. So my goal with this talk is to have everybody have at least one new way of thinking about weight management in their patients. And in order to do that, I'm really going to address obesity as a chronic disease and the pathophysiology of that disease. And then we'll move into a little bit on how to evaluate the patient. Tomorrow, I'll be talking about things that are really of interest to medical practitioners, and that is drugs, devices, bariatric surgery, and how to put a package of those things together to better help your patients with weight management. Okay, so let's begin. So these are the objectives. We want everybody to walk out of here with a little bit more knowledge than you currently have about appetite and energy balance regulation, how the brain, the fat, and the gut communicate with each other in the regulation of food intake and energy expenditure. And then to have a better understanding of what happens when our patients enter negative energy balance and begin to lose weight, and why weight loss, and especially weight loss maintenance, is so very difficult. And then lastly, we'll talk a bit about evaluating patients in practice and trying to formulate a therapeutic plan based on that evaluation. Okay, here's the first concept. So the guy on the left is looking at these logs, and he counts 4. And the guy on the right is looking at them, and he counts 3. Well, they're both right from their own perspective. The guy on the left says obesity is a BMI of 30 kilograms per meter squared or greater. And he's right because he's an epidemiologist. And the guy on the right says no. And the guy on the right says, well, how can that be? Because some of those people with a BMI of 30 or higher have no risk factors, they're perfectly healthy, they have no symptoms. How can obesity be a disease if you're defining it in that way? So I think it's very important that we define obesity, that we understand the definition of obesity. Okay, so our epidemiologists, those who are looking at populations, define obesity based on body size. And body size correlates on a population basis with body fat mass. And as BMI increases, we see increased risk for all the comorbidities: type 2 diabetes, cardiovascular disease, cancer, mortality. So there's this, and we know that the uptick begins at a BMI of about 25 in this population. And so that's how the definition of overweight was developed. It was developed based on these population studies. And then we see the curve getting much higher at a BMI of about 30. And so that's where the term obesity comes from. It's the increased risk for comorbidities and for mortality that occurs. But we need to understand that the population really determines the cut point. So let's get this under our belts first. Okay, I'm going to show you data from a study in Canada. Now, Canada is really great because it has lots of different ethnicities. And what they did in this study is they went out and did measurements of height and weight and blood tests. And then they did a factor analysis among 4 different ethnicities. So there were Europeans, and those are shown here in blue, the Aboriginal people of Canada shown in green, Chinese immigrants shown in yellow, and South Asians shown in pink. And so what they did is they clustered factors. So the glucose factor was composed of hemoglobin A1C, fasting glucose, and 2-hour postprandial glucose. And then they looked at the relationship between BMI and that composite glucose factor. And what you see at a BMI of 30 in people of European descent is equivalent to a BMI of 21 in South Asians. So what this tells you is that among individuals of South Asian descent, and even of Chinese and the Aboriginal people, they are at increased risk for having abnormal glucose metabolism at lower BMIs than a population of European descent. So we need to look at our BMI levels and health risk associations based on ethnicity. It's very important. Now let's look at a BMI and lipid factor from this same study. And indeed, a BMI of 30 in the European population is equivalent to a BMI of 22.5 in South Asians and intermediate for the other 2 ethnicities. Blood pressure is less tightly linked to BMI than these other risk factors. But a BMI in the people of European descent, the European Canadians, was equivalent to risk for abnormal blood pressure of 28.8, about 1 BMI unit less in South Asians. And look, in the Chinese immigrants, it was even lower. They were more susceptible to elevated blood pressure with lower BMIs among that Chinese population. So what this tells you is that the cut points, the risk for disease based on body size as measured by BMI, is very much dependent on ethnicity. And now I want to move into talking a little bit about how among BMI itself and definitions of obesity based on BMI, there's a whole variety of health risks within each one of those categories. And so this is something that was developed again in Canada and it's called the Edmonton Obesity Staging System. And so what this proposes is that obesity is actually associated with a whole variation in health risks. And those health risks can be medical, like abnormalities in glycemia, abnormalities in lipids, abnormalities in blood pressure, or they can be mental, the association of obesity with depression and mental health diseases, or they can be functional. So functional would be difficulty in walking, knee osteoarthritis, urinary stress incontinence, those sorts of symptoms that are associated with obesity. So stage 0 is when obesity is present, but there are none of those conditions. And stage 1 is when the conditions are preclinical or mild. Stage 2, they're more advanced. A comorbidity is present in the medical section of this. Stage 3 is end organ damage, when there's been actual damage to organ, and stage 4 is end-stage disease. So if you look at this staging system and apply it to a population and compare it according to BMI, we can learn some things. So here I'm showing you the CDC's National Health and Nutrition Examination surveys that are done. And I'm showing you on the right panel over in that 1988 to 94 survey, follow-up of those patients over 16 years. And here they're varied by BMI classification. So those lines represent overweight, class 1 obesity, class 2 obesity, and class 3 obesity. And you can see there's a lot of overlap in those lines. But if you use the Edmonton Obesity Staging System, you can see that there's a nice distinction that individuals who have more advanced disease have shortened life expectancy. Well, of course, this makes a lot of sense, but it's also true within each BMI category. And so here's what these investigators have done with that NHANES data. They've categorized it in the top left, class 3 obesity by EOSS staging, the top right, class 2 obesity, the bottom right, normal or overweight, and the bottom left, class 1 obesity. Excuse me. So, I think what this tells you is that health risk associations with obesity are important, that we need not to just rely on body size in developing a treatment plan for our patients. We need to look at all of the drivers of morbidity and mortality. And those drivers may be driven by obesity, but they're very important that they're there. So for example, among our patients with type 2 diabetes, 90% will be either overweight or have obesity. Among our patients who have overweight or obesity, only 30% have type 2 diabetes. So what we need to be looking at is not just the body size of our patients. We need to be looking at health risk indicators. So, how do we define obesity? We need to leave the epidemiologists alone. They can use BMI as a sole criteria for defining obesity. It's very good on a population basis. But we're not epidemiologists, I hope. Any epidemiologists here? No, we're clinicians. We have to treat individual patients, not populations. So for us, the definition of obesity requires both the cut point and the clinical status, the health risk assessment of the patient. So according to the World Health Organization, the diagnosis of obesity and the definition is that it's a condition where excess abnormal body fat impairs health. So those cut points may be different based on your patient population. So for Europeans, overweight is BMI 25 and up to 30. Obesity is a BMI of 30 and up. And waist circumference for women, which gives us more information because it tells us where body fat is located. It's not just about body size, it's about the pathological body fat, which tends to be central. So the cut points for Europeans, for women, is a waist circumference of 35 inches for women and 40 inches for men. For our Asians, and many of us have Asians, including people from India, are in this category. For those individuals, the cut point should be lower. A BMI of 23 is when we start worrying about overweight in those populations, and obesity, a BMI of just 25. And of course, the waist circumference cut points are lower because those populations are at increased risk for obesity-associated comorbidities at lower BMIs. And particularly for the Asians, they tend not to store a lot of excess body fat in the thighs and hips. They tend to store their excess body fat centrally. So, is obesity a disease? Well, I think the old way of thinking would be that no, it's not a disease. It can contribute to diseases. It's a risk factor for developing diseases. But I think if you look at it in a new way, and I hope I can convince you that obesity is an impairment of normal body functioning, and that's the normal functioning of our energy balance regulatory systems that produces symptoms. And we're going to be going into the pathophysiology of obesity in a minute. And then we used to think, well, how can obesity be a disease if there are people with a BMI of 30 or greater who have absolutely normal health status? Well, I don't think we need to use BMI to name call. Remember, we're clinicians, and the diagnosis of obesity is made both upon body size and the presence of health risk. And I think what leads to thinking of obesity as not a disease, it leads you to think, oh, well, people could just change their habits and they could get over this problem if they really tried. It must be a problem of personal choices. But now we know that inherited and environmental factors both strongly influence risk for overweight and obesity. And once weight is gained, the physiology, it resists weight loss. And that's what we're going to be talking about next. So, the experts would agree that obesity is a disease, and even the AACE members, American Association of Clinical Endocrinologists, think this problem, this disparity between BMI criteria for the term obesity and clinical terms for obesity is that we should rename it. We should call it ABCD. Has anybody heard of this? Well, it's not exactly taking hold of the imagination. But they want to call it adiposity-based chronic disease because they're very frustrated that people are pushing back in calling obesity not a disease. The point of this initial part of this talk is that, yes, indeed, we need to be thinking about it as a disease. We can call it ABCD, or we can call it just plain obesity, but it's a disease. And it's a chronic disease. It's a chronic disease because weight loss is so difficult. And once our patients are successful with weight loss, we've all had this experience. Weight regain is so darn common. We've all had the experience of a patient losing weight, being successful with that weight loss, and then slowly we've seen that weight regain. And that's all due to the neurobiology around food intake and energy expenditure and these physiologic adaptations to weight loss. There are changes in appetite, there are changes in susceptibility to food cues, and there's a reduction in total energy expenditure that results in this nearly inevitable weight regain unless we have special approaches to it. So I think the old way of thinking would be that obesity is caused by bad lifestyle choices. Yeah, but there's some biology behind that. And it's probably better to think of this as it's being genetic susceptibility to an obesogenic environment. And to illustrate that, I want to show you this simple diagram of body weight regulation. And this is simple. This is the simplest one I can find. But I put this in there because if you go online, you can study it. Now, stop looking at that and just listen to me for a minute. So, when you came down this morning, you looked around at the continental breakfast and the coffee and everything, and you were hungry. Was everybody a little hungry this morning? Yeah, what was causing that? There's a hormone in the stomach called ghrelin, and it goes to the brain and it peaks and it drives your behavior to eat food. And so after breakfast, after you ate something, about 20 minutes later, you weren't really hungry anymore. What was causing that? Well, once food enters the gut, there are peptides that are released by the gut, GLP-1, other peptides that go to the brain and tell the brain that food is on the way, that we can stop eating, that we're satiated for our meal. Insulin produced by the pancreas also has this effect, as does amylin. So there are 9 different hormones that we currently know about, and probably some that we don't know about, that are helping to promote satiety. And one hormone, ghrelin, that is promoting hunger. So this system where we get hungry and we eat and then we stop eating and then we feel satiated until we get hungry again, that is called the homeostatic system. And it's primarily regulated out of the hypothalamus. And when the hypothalamus is damaged, we see some of the most severe cases of obesity. So young children who have craniopharyngioma and are surgically treated for that can end up with hypothalamic damage and very severe obesity. One of my patients had craniopharyngioma. She was a high school cheerleader. She weighed about 99 pounds. She developed hyperphagia. She was hungry in recovery. She gained 100 pounds in the first year post-surgery. The second year, she gained another 100 pounds. The hypothalamus is the command center for this homeostatic regulation of hunger and satiety. Now, sometimes we eat when we're not hungry. So if we go by the buffet and we're no longer hungry, but there's something particularly appealing to us out there, it's frequently sweets or something very savory, we'll want to eat that. That's coming from a different part of the brain. That is the reward system. And so these foods that have a lot of reward value will override the homeostatic system, and we'll eat them because we get a lot of pleasure out of them. So there's a lot of commonality there between addiction and this reward system that's occurring. So what causes obesity? I love to show this picture because these are identical twins, and they share 100% of the same DNA. They're raised in the same environment, and I want you to notice between each member of the pair how much concordance there is in body habitus. These are fraternal twins. They share 50% of the same DNA, and I want you to notice how much discordance there is in each member of the twin pair. What does this tell you? This tells you that genes are very important in risk for obesity within a given environment. The genes aren't the only thing. The environment is very important. The genes load the gun, the environment pulls the trigger. But we also know that once individuals develop overweight and obesity, there are changes that we can measure in their brain. The last bullet on here is something that we think is part of the pathophysiology, and we can actually demonstrate gliosis in the hypothalamus of individuals with severe obesity. So there's damage to that regulatory system. And we know that we have these fMRI studies that we do where we show that stress changes the relationship that you have with these highly rewarding food. It makes you more susceptible to them. A little bit of hypoglycemia, mild hypoglycemia, also increases your susceptibility to these reward foods. And we know that the difference between people with obesity and who are lean is profound in these fMRI studies. So there are functional changes that occur with obesity, and we need to be aware of those. So, the problem with obesity is there are more than currently 150 genes that have been associated in these genome-wide association studies with BMI. And there are over 100 that have been associated with waist circumference. So what's going on in our population is that these common variants of genes, this is not like a single gene defect that's causing this. Although we do have that, there are a few, they're very rare. Like individuals can have a single gene defect in leptin and have severe obesity. But the common garden variety obesity is related to multiple genes, and it's common variants of those genes. But when they're aggregated, when you aggregate these common variants, you increase your risk. So here we're looking at, I think this is about 16 genetic variants that they were looking at. And of course, in the population, it assumes a nice bell-shaped distribution. But if you look at BMI in that yellow line, as you accrue more of those gene variants, you see the BMI increasing. So what's going on with our patients with obesity is that they have inherited the royal flush of genes that predispose to obesity. Furthermore, there are life events that can trigger obesity and contribute to weight gain. So certainly aging is one, and everyone knows this. As we age, there are changes in distribution of body fat, and especially for women, postmenopausal women are going to accrue more central body fat, and they're going to lose body fat in the hips and thighs. Pregnancy, there's a subgroup of women who are very predisposed to retain weight after pregnancy. Same thing with menopause. Not every woman is susceptible to this, but there's a subgroup of women who do experience a lot of weight gain around that menopausal period. Look, iatrogenic weight gain. Doctors, providers, the medications that you write can drive weight gain. This is the biology of obesity. A lot of these medications are centrally acting. So especially our antidepressant medicines and our atypical antipsychotics can promote weight gain. And some of the medications that we give for diabetes, insulin and the insulin secretagogues can cause weight gain. We know that. But this is because insulin is a powerful growth factor. And then beta blockers and some other medications. Tomorrow we'll talk some more about that. But then there are medical conditions, damage to the hypothalamus, Cushing syndrome, that can be predisposed to obesity. Smoking cessation, yeah, that's associated with a little bit of weight gain, but it can be blocked with a good dietary intervention. And smoking cessation is very important. Keeping smoking to prevent weight gain is not an excuse. Now, sleep deprivation, that is a very common cause of weight gain, and it also helps prevent patients from being successful with weight loss. And then there are other environmental factors. We think gut microbiota are important. We don't know how to harness that knowledge yet. And then others. Nutritional programming, the epigenetic effects that can occur during pregnancy are very, very important. It's why we need all mothers to be in optimal health prior to pregnancy, because what we believe happens during pregnancy is methylation of the genome. So the genes are there, but some of them are going to be expressed and some of them are going to be blocked by this methylation that occurs, and it can be that if the mother's metabolic health is not good, it can transmit increased risk for obesity and metabolic complications in adulthood for that fetus. Okay, so what about this weight regain? Well, we used to think we just reduce the patient, end of problem. But now we know that obesity is a chronic relapsing condition. And we used to think that, well, the reason patients were regaining that weight was they just going back to their old bad habits. They just need to try harder. But now we know that there are real biologic and physiologic changes that occur. And we used to think of more willpower, they could do it. But now we know that treatments work if they are used, and we need special approaches to get over this issue with weight regain. So this is an example of the metabolic handicap. So once you begin to lose weight, this rapidly kicks in. Very early in negative energy balance, we start to be able to detect a reduction in metabolic rate that is disproportionate to the reduction in your body size. So total daily energy expenditure with about 10% weight loss is reduced by about 500 calories a day for a diet that's about 2,700 calories at baseline on average. This is both in resting energy expenditure and in activity energy expenditure. This activity is the non-exercise activity that occurs. It's the fidgeting that produces a bit of energy expenditure. But the greatest effect is on that activity component, and that's why physical activity is so important as a preventive for weight regain, and we're going to be talking about that in a minute. But it's not just the metabolism side, it's the hunger and satiety side that get affected. So this is a study where patients were brought into an inpatient unit. They were reduced by 14% on a very strict diet over 10 weeks. Then they were allowed to leave the unit, but they were counseled to try to keep the weight off, and they did pretty good. At the end of a year out of the unit, they were still down by 9%. Well, At week 10, there's a reduction in leptin of not 14%, which is the weight reduction, but by 65%. So leptin is a hormone that's produced by body fat. It's proportional to the amount of body fat. Individuals with obesity have very high leptin levels. So leptin goes to the brain and it tells the brain what body fat stores are. And when leptin falls, the brain reduces metabolic rate and increases food intake. So leptin, this disproportionate reduction in leptin, is a powerful driver of weight regain. And at week 62, when weight is down by 9%, leptin is still down disproportionately by 35%. And this corresponds to changes in hunger and desire to eat. So what the graphs on the right show in gray is the baseline around before a meal. There's high hunger, there's the meal, the hunger goes down, and over about 6 hours after you can see hunger levels lie. The values in blue are at 10 weeks and at 62 weeks, and they're higher. There's more hunger, there's more desire to eat after the weight loss has occurred. So there are measurable differences in hunger and satiety that occur after weight loss that make it difficult for patients to maintain lost weight. And these correspond to changes in those hormones. There's higher levels of ghrelin, and there are lower levels of all those hormones that promote satiety. So this is the biology of what's going on in our patients and why they are struggling so mightily to maintain that very hard-won weight loss. So how much weight do we actually need to help our patients lose? Do we need to get them all back to a BMI of 25 or less or 30 or less? Well, different tissues respond differently to weight loss. And we can get, depending on our targeted outcome, we can get a lot of benefit with less weight loss. There we go. So this is a quote from David Allison, who was talking about how a little bit of weight loss has a curious power, especially in prevention of type 2 diabetes. It's so curious. You know, look in DPP, it was 7% weight loss, and there was a reduction in diabetes risk of 58%. 7%, 58%. They were obese before, they're still obese, but they've reduced their risk by 58%. What is that about? What's going on there? Why is that? What is this curious power of modest weight loss? Well, look at this analysis of the DPP data. And what I'm showing you here on the x-axis, the horizontal axis, is change in weight in kilograms from baseline. And on the y-axis, the vertical axis, the diabetes incidence rate per 100 person years. In the first 5 kilograms, you get that's what, 11 pounds. There's an enormous risk reduction. And 10 kilograms maximizes, 22 pounds maximizes risk for conversion, reduction in risk for conversion from IGT to type 2 diabetes. Wow, we do not need to get our patients with prediabetes down to a BMI 25 or 22 or anything. We can get a lot of health benefit just by 22-pound risk reduction. That's incredible. I'll take that any day because that amount of weight loss is achievable. Now, why is that? Well, this is a study that was done in WashU in St. Louis, and it was done by Sam Klein and his group, and they took people and measured them with these advanced clinical endpoints at baselines. MRIs, insulin clamps of different tissues. They did biopsies. They looked at all the risk factors, and they measured them at baseline. They reduced them by 5%, measured them again, reduced them to 11%, measured them again, reduced them to 16%, and measured them again. So I'm showing you on the left intra-abdominal adipose tissue. This is measured by MRI, and you can see there's a stepwise reduction. But it's so interesting that at that 16% weight loss, there's a 30% reduction. It's disproportionate. But it's even more obvious if you're looking at intrahepatic triglyceride. This is fat in the liver. And you see that 16% weight loss, there's a 60% reduction in liver fat. That's disproportionate. That's very, very good. And so the bad fat is going out of there first. That's part of the reason why we're getting the benefit. But what about inflammatory factors? Well, if you can tell here that it takes at least 16% to start to see a benefit in C-reactive protein, and it took 11% or more for many of those others. Inflammatory factors. So we need more weight loss to really get improvements in inflammatory factors. And for free fatty acids, those are circulating free fatty acids are associated with insulin resistance. We didn't really see a benefit in those until about 11% weight loss. So overall in this study, what it showed you is that you start to get a lot of benefit with just 5% weight loss. Continued benefit in terms of reduction in fat in the liver and in intra-abdominal adipose tissue. But when you measure insulin sensitivity in different organs, adipose tissue insulin sensitivity and liver insulin sensitivity is maximized at just 5% weight loss. That is great. Now, more weight loss, continued benefits in terms of muscle insulin sensitivity, and you didn't really get improvements in these markers that he was measuring of adipose tissue biopsy until 11% weight loss. And for our inflammatory markers, we need to aim for more, about 16% weight loss. So, what we see in people with type 2 diabetes, this is more advanced than prediabetes, established type 2 diabetes, is we get more weight loss, more improvement. I'm showing you here different categories of weight loss. So hemoglobin A1C on the left, fasting glucose on the right, and each of those categories are stable weight, 2 to 5% weight loss, 5 to 10%, 10 to 15%, and greater than 15% weight loss. Look at that. You start to see improvement at 5, more weight loss, more improvement. Same thing for fasting glucose. And this is also true for, on the first panel, blood pressure, systolic and diastolic, triglycerides, and on the panel on the right, HDL and LDL. So HDL starts to improve at about in that 5 to 10% range, but LDL we don't really see a difference. But these patients in this study were heavily treated with statins, and even though we didn't see a change in statins, we did see a reduction in the medications that they needed for LDL lowering. So there's benefit there. So overall, the way we need to think about how much weight our patients need to lose is depending on what's our targeted goal for improvement. If it's just diabetes prevention, we can probably get by with a little less weight loss. But we really need to be looking at the end point, not the weight. It really needs to be driven by our effect on these targeted endpoints. Because if we really want to get improvements in inflammation, we're going to have to get more weight loss. And so for our NASH activity scores and apnea-hypopnea index, it takes more weight loss than it does to get to really see improvements in some of these other markers. And I believe to really get improvements in reduction in cardiovascular events, we're going to have to get 15% or more weight loss in our patients to really have that sort of benefit. So the field is moving to try to produce more weight loss for these patients, those EOS patients who are in stage 2 and 3, and to be able to produce more weight loss to get more health benefit. Now, one thing people think is they tend to be a little negative about our patients who have more severe overweight. So, are our patients at higher BMI categories, do they respond the same as these individuals who have lower BMI categories? So here I'm showing you Class 1 obesity in pale green, that's 30 to 35. Class 2 in medium green, that's 35 to 40. And then 40 and up in dark green. And so what we're looking at is that same data that I showed you about the benefits of weight loss in this population. And you can see in the first panel, there was no significant difference in the ability to lose percentage weight from baseline by BMI category. There's no difference in response of A1C in that amount of weight loss. It was modest weight loss. It was about 9%. A1C improvements, no difference by BMI category. Same thing for systolic blood pressure, diastolic blood pressure, triglycerides, and LDL. The higher BMI categories responded less well with improvements in HDL, but that was it. So we need to not be pessimistic about our patients who have BMIs of 40, 45. We need to be trying equally hard on those patients to get weight loss. So I think understanding the biology and the physiology really helps us in how we see our patients. So we can see this patient and we used to think the old way of thinking would be that, well, her lifestyle is a personal choice. She just needs to eat less and exercise more. I'll just tell her to lose weight. And if she struggles, well, it's her fault. And she doesn't need medications because she ought to be able to do this on her own. And I have to admit to you, I used to think about patients in this way, but I don't think about them in that way anymore. Now I look at her and I think she carries genes to resist loss and promote gain. Stress, mood, medications, life events may also have promoted her gain. Losing weight requires skills, and it's my job to teach her those skills, to coach her. Weight regain is an expected reaction to metabolic and physiologic adaptation, and I'm going to have to do some special approaches to make her successful and to keep the weight off. So I think understanding, changing our thinking about the pathophysiology of the disease also changes how we treat our patients. So now let's finish up talking a little bit about how we approach patients in the office. And we have 15 minutes left, so I'm going to try to do this part in about 5 minutes so we can talk back and forth for 10. So you're going to identify patients in two ways. Look, you're getting a BMI every visit as part of the electronic health record. It's one of the core measures. So you're going to identify people who are in those categories, the first step in screening, and you're going to be looking at their health risk. Or you're going to be treating somebody for diabetes or some comorbidity, and you're going to go and look back and think, well, is excess body fat an issue in this patient? So the algorithm that I like best for how we need to be evaluating and staging people is this AACE algorithm. And you can get it online and go through it. But basically, the recommended procedure is to evaluate the patient with your standard history and physical, but also to look at past events across the patient's weight history. What were drivers of weight gain? What were the successes that the patients had? Because you can build on that. You can figure out what is promoting weight gain and remove it, and you can, if it worked in the past, it's likely to work again. So adding a bit to the medical history and physical is part of that. And then we make the diagnosis not just on BMI, but upon the patient's health risk. And we categorize patients as having mild to moderate, or severe health risks associated with their excess body fat. And so for individuals who are overweight or obese but have no complications, well, those are the patients that we need to really just be giving advice about good lifestyle. And if they want to lose weight, that's perfectly fine. But we do not intensify therapy for those patients because there's no real need to. But for patients who have established comorbidities, we need to set higher weight loss goals, 5 to 15%, and we need to be more intensive in our approaches. And the same thing is true for patients who have more severe comorbidities. We need to be more aggressive, more intensive in our approaches to those patients. So we intensify our therapy. There are a number of techniques that help. One is more face time. That works. So putting patients in a group setting or individual counseling settings with a dietitian or even a commercial program to give more face time and more contact time, that works. More structure to the diet. Meal replacements give structure and they help patients navigate the smorgasbord of life. Liquid diets have a special place to induce weight loss if they're followed by the skills training of a lifestyle intervention. There's a new approach of alternate day fasting or 14-hour fasting that has an evidence base behind it, and that's a trick that can be used to help patients who are struggling to lose weight. We also have campaigns that we'll sometimes use. We'll have set a goal, walking goal. We're going to walk to Las Vegas and set the goal and compete among each other. But I think we, as healthcare providers, we need to be more open to medications, to devices, and to referral for surgery, because this is a serious chronic disease. It can be, and when it is, we need to address it appropriately. So we know this about weight loss. We know that if we want to produce weight loss, it's all about energy deficit. And so when in losing weight, it's much more efficient to address food intake, the diet. But to maintain that weight loss, we are trying to achieve energy balance. And it's the best way to maintain weight loss is shown on the bottom of this picture. We know that physical activity is absolutely essential to maintain lost weight. But it's a lot of physical activity. It's more than is required for cardiovascular fitness. It's about 2,400 kilocalories per week, according to the National Weight Loss Registry. Yeah, regular meals are important. A healthy diet is important. One meal replacement a day can work. But that physical activity is key. And another key, continuing medications is one of the best things about our new medications for obesity is they'll keep the weight off as long as patients are taking them. So maintaining weight loss with continued medications is very important. So that's the big overview I wanted to give you, that obesity is a complex chronic disease. We need to understand the pathophysiology if we're going to be effective in treating it, and we need to match the therapeutic plan to the patient's health risk status, and that we can intensify our therapy if patients are struggling. Good weight management is good health management. Good weight management is good diabetes management. We need to be doing a better job at weight management. And I hope I have given you all a new way of thinking a little bit about obesity and its management. And I want to thank you for being so patient with me. So the question is, what about getting these medications paid for? Yeah, it's everybody's first complaint. So there is progress being made. And overall, if you look at commercial insurance, not Medicare, not Medicaid, but commercial insurance, among those, there's about, overall in the United States, about 60% of plans will have some form of payment, a reimbursement for medications approved for chronic weight management. But there's a lot of variation across the country, and it's all dependent on the employer, because the employer sets the plan. So the human resources departments of the employers go in and they define what the health plan is going to be. The insurance companies, they just execute the plan. So the more progressive, the more wise the employer, the better the coverage tends to be. So for example, FedEx, they're good about paying for these medications. Many health organizations, especially the big ones, it's like big hospital systems in Atlanta or whatever your town happens to be. Also banks. So the more progressive the employer, the more likely they are to be doing these things. Unfortunately, the state of Louisiana does not cover them. My employer, the state of Louisiana, Office of Group Benefits does not cover them. Medicaid does not cover them. Medicare does not cover them. So there's an act in Congress to try to get Medicare to cover these medications because, you know, CMS kind of leads the way in sort of setting the standards because their reimbursement is based upon, you know, it's U.S. Preventive Services Task Force and this other evidence base to prove it. It's coming, but it's a pain in the neck.
In the back.
Yes, you mentioned several drugs cause weight gain. Do they actually cause them, you know, particularly like SSRIs, antidepressants, actually cause weight gain, or is it more like stimulate the appetite and the patient eats more, or the mechanism?
Well, I think if you stimulate appetite, you cause weight gain. You know, so so we'll be talking more about this tomorrow, but the medications, especially those that have a central effect, are associated with weight gain. So among the antidepressants, and it's not every patient gets weight gain with every antidepressant medication. You know, so there's a group of susceptible individuals to weight gain. So the way to look at it is, you know, you might have 20% of the population that you're prescribing Paxil to that will experience weight gain. But when they get it, it's not pleasant at all. So there are some medications that are associated with weight loss that are used for depression, and bupropion is the one, but not every patient on bupropion is going to lose weight. So the way that weight gain occurs is through the central action of these drugs, and it's through food intake. So, you know, appetite is it is something we can measure, but the way our patients describe it is, you know, it's highly individual. So the data I showed you were comparisons from these. What we do is we do visual analog scales where patients report their hunger and desire to eat along a continuous line, and then we measure that and make a graph out of it. But it's different among every individual. So it's a highly individual thing. And our words for how we describe this is different. So for example, in that study that I showed you that there was measurable increases in appetite and desire to eat, well, you know, when you talk to patients, they don't say, after they've lost weight, they don't say, I'm starving, I gotta eat. It's measurable, but they don't complain about it. It slowly produces a small amount of increase in food intake. So in general, for the antidepressants, the weight gain, they're not ravenous, they don't complain of hunger, but there is this measurable increase in food intake. Did that answer your question?
Yes, ma'am, thanks.
Oh, yeah.
At the beginning of your presentation, you had this showed about Europeans and Asians.
Yeah.
What about African Americans and Hispanics who have very high rates of obesity? Do you have any information for those populations?
Yeah. So not in that particular study, but yeah. So when you go on the CDC websites, they have all the information. They will show you in the U.S. Health risk. By state, by race. It's really, it's very good. But yes, African American women are at increased risk for obesity. The men have the same rates as Caucasian men. But there are increased risks of obesity among African American women. The Hispanic population is a population that tends to be at increased risk for type 2 diabetes at lower BMI levels. I think that may be related to the gene pool in our Hispanic population that's really Native Americans, that Mexicans and such, that gene pool puts them at increased risk for this visceral adiposity and increased risk for type 2 diabetes. So yeah, there are racial differences in that. The African American experience is very interesting.
We have time for one more question. Dr. Ryan? Hello.
Yes. I was wondering, with the medications, is there a medication that you're more likely to find useful? I mean, there's a lot of confusion over the medications.
I am going to spend a lot of time on that tomorrow. See you, same time, same place.
Whole hour
Yep,
and surgery, talk about
yeah.
the therapy.
So two people with the same BMI could have different body fat percentages.
Absolutely.
Are you seeing the same difference in people
That's
with a
why we
lower
measure
body
waist
fat?
circumference.
Okay.
Yeah.
I was going to relate it to the change in diabetes, the
Yeah.
hepatic steatosis, and all that.
Yeah.
You see the same regardless, the same changes regardless if they lose the weight?
You can look at either waist circumference as a predictor or BMI as a predictor, because if it's a big enough population, they're going to be the same. It's going to show you the same sort of thing.
Okay. Thank you.
Yeah. But I think, the big example is the physically fit bodybuilding Marine who has a BMI of 31 and a waist circumference of 31. So, so I think what we need to be thinking about is not judging people by body size. We need to be more tolerant of people's body size and less tolerant of excess body fat that impairs health. We need to shift away from BMI and more onto body fat being a driver of disease.
Okay, thank you, Dr. Ryan.
Thank you.